Great, so Rachel, I think you guys can hear me and see my screen.
Yep, Joe, there are about 33 attendees on right now, so you can start whenever you're ready.
Great, thank you. Well, good morning, good afternoon, and good evening to everyone who's joining us across the world today for a walkthrough of WHO's COVID-19 Essential Supplies Forecasting Tool, or EFST. We're brought today by the International Association of Public Health Statisticians, or IAPHL, to the first of this two-part series on freely available tools to support quantification of COVID-19 related commodities. Hopefully all of you are familiar with IAPHL, but if you are not a member, or if you're a member but you have colleagues who are not members, I encourage you to join and have your colleagues join as well. I'll share a link towards the end of this session where you can do so. During the hour that we have together today, we'll take an in-depth look at this forecasting tool from the WHO, followed by time that has been set aside for you to have a chance to ask questions of the builders of this tool. As a matter of housekeeping, just given the number of folks that we have on the call today, you'll notice that you're muted during the session, but feel free to type questions into the Q&A feature that you can see towards the side of your screen. Feel free to type in those questions as we go along, and those questions will be addressed either in the Q&A chat itself, or they'll be called out for discussion during the Q&A session. Next week at the same time, in a similar place, is the second of our two-part series in which we'll look at a tool which focuses specifically on supply planning. Our team of panelists today includes 3 representatives from CHI who helped to develop the tool. Who'll be leading us through the walkthrough of it. They include Senior Director for Analytics and Implementation Research, Justin Graves, Senior Technical Advisor with Applied Analytics, and Zach Panos, Manager with HIV Intelligence Team. And I should introduce myself as well. I'm Joe McCord. I'm a Supply Chain Technical Advisor with JSI's Center for Healthcare Logistics, and also a co-founder of MDOS, which builds and operates healthcare diagnostic centers. I'll give just some quick technical context on some of the terminology we're using today before we jump into the walkthrough. Quantification is the process of estimating the quantity and cost of the products required for a specific health program or service, and also determining when those products should be procured and delivered in order to ensure an uninterrupted supply. You'll notice in the diagram at the right here, which lays out the entire process of quantification, that there are a number of major steps involved in it. After a preparation or scoping phase, forecasting is specifically the process of determining the numbers of products that you expect to be used or dispensed by the program over a specific period of time in the future. Typically in forecasting, we'll use historical data on the number of products used or assumptions about the size of the program in the future and the dispensing protocols to make that estimate of future use. Forecasting then informs the stage of supply planning, which is where we take those expected requirements and use them to decide the quantities to actually be ordered and when those shipment orders should be placed to ensure that uninterrupted supply. So for example, forecasting might tell me that I should expect my health centers to use 1,095 masks over the next 6 months. And based on that, a supply plan would tell me that I need to order 2 shipments of X and Y amounts in order to keep the right amount of masks in stock during that time. So again, forecasting is the process supported by the tool we'll be looking at today, while next week is when we'll take a look at a tool to support supply planning. So with that, I will now hand things over to our colleagues at CHI to lead us through the tool walkthrough.
Great, thank you, Joe. And thank you to JSI for organizing today's webinar. And thank you to all of you for joining. My name is Elizabeth McCarthy, and I lead CHI's Analytics and Implementation Research team. Today, after some brief remarks, Zach Panos and Justin Graves will do a walkthrough of the COVID-19 Essential Supplies Forecasting tool. We expect this to take about 40 minutes, after which we'll take some questions and any feedback input that you all have for us. So just quickly for background, the WHO developed the COVID-19 Essential Supplies Forecasting Tool, or EFST, to help countries quantify their need for COVID-19 essential supplies, particularly personal protective equipment, diagnostics, and biomedical equipment. And CHI has supported this tool development. So the tool builds on existing tools used by the operations, supply, and logistics team at WHO to respond to health emergencies. And WHO clinical and diagnostics experts have guided all of the key assumptions in the tool. As Justin will describe later, the tool's engine relies on projected weekly case numbers, and users can calculate supply needs assuming the current absorptive capacity of the existing health system, or they can run unconstrained scenarios not limited by the existing number of healthcare workers, hospital beds, diagnostic platforms, or oxygen supply. The tool was built primarily for ministries of health and other government decision makers and stakeholders involved in COVID-19 planning and preparedness. It can be used at the national and subnational levels in certain settings, such as in a humanitarian response or in prisons, or to respond to areas with a sudden outbreak. So updates to the tool are underway and should include estimates of PPE for non-COVID essential health services. We're strengthening linkages with infectious disease modeling groups. We anticipate new diagnostics in the pipeline, and we're making adjustments to the biomedical equipment section with input from biomedical experts. So with that, I invite Jack Panos to take over for the walkthrough. Thank you.
Thanks, Elizabeth. I just want to confirm that my audio and screen sharing is coming across.
Yes.
Okay, great. Thanks, Elizabeth and JSI for having us here today to walk through the WHO COVID-19 EFST tool. So this tool is downloadable from the WHO website, and I just want to highlight a few quick tabs before we get into the meat of the tool. The first is this tool overview, which provides some high-level overview of a number of the tabs, assumptions, and toggles within the tool. And there's also a downloadable FAQ document that comes along with this that has more details on how to use the tool and implement it in a given context. So those are both resources for using the tool beyond this webinar. So the first real input tab is for users to use is the input tab. And here is where we have consolidated nearly all of the potential inputs that a user may edit in the course of using this tool. If you're familiar with this is the version 2.0 of this tool. If you're familiar with version 1 that was released, I believe in late April, a number of these inputs were not editable by the user. They were set by the WHO. And so in the version 2.0 that went live, I guess about a month ago, these have now all been brought to the fore, so users are able to customize this tool to fit their given needs and context. So when using the tool, the first section is the country or territory selection. Here, the default is set to run the tool for a given country, where you can select from this drop-down menu. However, if you're interested in using this tool subnationally for a given region or for a an area such as a prison or a refugee camp, you're able to toggle this manual entry radio button, and then you can enter in the population of the area that you are wanting to quantify for. So the tool does have the ability to do both national level quantification as well as subnational if you utilize this manual entry radio button. So we'll go back over country for the rest of this walkthrough. It takes time before process occasionally. So you select the country, it will populate the estimated 2020 population. Then users will enter the current cumulative case count. So it has to be at least one. And there are, of course, a number of sources you can use for this. Let's, just for the sake of argument, I don't know the latest Zambia case count, but let's say it's 2,000. And so that gets entered in. Then the rest of this tab contains all of the input assumptions for the tool to run. And there's really two sort of sections for how this is laid out. In column E, we have all of the reference or default values. And so these are default values that have been decided upon working with WHO and other technical experts that users can use as a reference if they do not know or have a different estimate for a given context. And so for all of the inputs, which are designated in blue cells, we have this reference value that can be used as well. However, if the user would like to just use all of the reference values and not input any of their own values, the user just needs to click on this radio button here. And you'll see that all of the inputs go away, and then the reference values get highlighted in this light yellow color, and the tool will use all of the reference values. So this provides a way to sort of quickly get into the outputs of the tool if you would just like to use the standard assumptions that have been supplied by WHO and other experts. So that's how the tool is set, the input tab is set to work. So I'll walk through the rest of the sections on this tab. The first section is on patients and case severity. And here users can enter in the percent breakdown of cases across 4 different severity types. So we have mild patients and moderate patients who likely need isolation. We have severe patients who are admitted into hospital needing some sort of oxygen therapy. And then we have critical patients, which makes up the balance. Which again are admitted into the hospital and need some sort of ventilation. So either invasive mechanical ventilation or non-invasive ventilation. The user can also input the length of stay for each of these case severity types. And note that these must be entered in terms of weeks in whole numbers. So 1 week, 2 week, 3 week, etc. And so again, for the cases that are isolating either at home or in some sort of community center, or for severe and critical cases, those patients that are hospitalized, how long they're actually in the hospital for. And then finally, we have these case fatality rates. And the tool is not designed as a mortality calculation tool. And so these are simply used to impact diagnostic testing. Users have the option of deciding to test patients upon release, so potentially 2 negative tests in a row while they're in the hospital to confirm their negative status, but we wouldn't be testing patients that unfortunately died. And so that's what these case fatality rates are used to calculate. The next section covers healthcare workers and other related staff. And just a note here is that this section is really used, as most of the tool is, to estimate PPE and other equipment. This is not used to differentiate tasks by cadre. It's really about quantifying the amount of PPE that may be used over the course of taking care of a patient either in isolation or in the hospital. So the first input is the total number of healthcare workers in the country or region. And you can see on the right that this value is pulled in as the reference dynamically based on information from the WHO Global Health Observatory data set. And then of this total, in this example, 15,000 or so healthcare workers, the user then inputs the percents that are not activated for COVID care. So those that will continue to do sort of their other essential functions and not be pulled into the COVID response. And then of those who are brought into the COVID response, what percent will be used to treat hospitalized inpatients? And then what percent will be used for screening and triaging of suspected COVID-19 cases? And just to highlight that the default value is 40% of healthcare workers will not be activated for COVID-19 care. Then there are a number of other healthcare worker and staffing ratios. So here for hospitalized inpatient care, users can enter the number of healthcare workers, cleaners, ambulance personnel, and biomedical engineers per bed, as well as the number of cases that are screened or triaged per healthcare worker per day. We've also allowed the user to input the potential use of informal caregivers, either in hospital or those who are there for mild and moderate patients who are isolating. Again, this is really just to inform PPE needs, such as masks or gloves. The next section is this hospital infrastructure section, where similarly, reference data from the Global Health Observatory is pulled in for the number of hospital beds in country across all levels of care. And then users have to enter the percent that are not allocated for COVID-19. Again, we have that default set to 40%. And then what percent are available for critical patients? And again, these are patients that require some level of ventilation, whether mechanical or invasive mechanical or non-invasive ventilation. And then the balance is allocated to those severe patients who are hospitalized but require oxygen. So if in a given context, there is really no ability to provide critical level care for patients, you would enter in this percent available for critical patients as 0. And then the tool would not calculate those ventilation type commodities, as there wouldn't be the ability to provide that care. Scrolling down, the next section focuses on labs and testing. And here is a sort of a large update from the initial version of the tool. In the initial version of the tool, we calculated the number of tests needed per day based on varying testing algorithms, with no sort of cap to the ability for a country or region to really absorb those tests and run them on the existing machines in country. And so what this section does, we've called it the max tests per day module, is this estimates the total number of tests per day that a country or region is able to run. And that is used as the cap, really saying this is the maximum number of COVID-19 tests that a country could absorb with their given capacity. And so it sort of grounds the testing output in reality for a given country. And so there's some instructions here, but how this generally works is across 3 types of testing platforms. So high throughput conventional platforms such as Roche or Abbott machines. We have near patient PCR machines. So right now that's the Cephia Gene Experts, as well as manual platforms for PCR. The user enters in the number of platforms available for COVID-19. And again, we have reference values that are based on WHO estimates of what is in a given country. The user enters in the number of shifts per day that the machine is running, the number of days per week that it's running, and then what the capacity is for COVID-19 testing. So either fully dedicated all the way down to very limited capacity, about 25% of the capacity for COVID-19 tests. And so once this is all entered in, the tool calculates the max testing capacity per day, which you can see here is about 10,000 tests. And so the user can either leave this here as the testing cap, or if they're interested in running an unconstrained scenario that is not limited by testing capacity, simply enter in, we've said 100 billion, which is enough that this will be considered unlimited testing. So there still is the option to run the EFST with unlimited testing. We also recognize that countries may be wanting to increase their lab capacity through purchasing either near-patient PCR machines or manual platforms. And so users are able to enter in the number of platforms that they are looking to purchase as part of the COVID-19 response. So you could say maybe 10 Cepheid Gene Expert 2 module systems and 20 4-module systems. And the tool will calculate the additional capacity for testing per day based on these new platforms being added. And then these platforms will be quantified for in the results. And then there are a number of other inputs around lab staff, those that are available for the COVID response, and some other inputs around lab operations and transport. And finally, on the inputs tab, there are assumptions around oxygen use, and in particular, the flow rate per bed in terms of liters per minute. And so here we've broken this up by severe patients and then critical patients that need non-invasive ventilation, as well as critical patients that need invasive mechanical ventilation. And as Elizabeth alluded, we will be making some updates in a version 2.1 around oxygen use that will provide a little bit more flexibility in terms of these inputs here. So this tab really covers all of the inputs for the back end of the tool to run. So let me then jump to another, or really the final inputs tab section, which is the tab for equipment use. And so there are, of course, a number of commodities that this tool quantifies for. And so we've put those on a separate tab. So you can click on this link or just go to the equipment list and usage tab, which takes you to the tab that has all of the commodities and then the assumptions around commodity use. So this is a rather large tab, so let me orient you to how this is set up. So here on the left, we have all of the commodities and equipment that the tool quantifies for organized by category. So IPC, hygiene, personal protective equipment, diagnostics, case management, drugs and consumables, and then a number of biomedical equipment commodities as well. So the tab lists the item, the unit of the item, whether or not it's reusable, and then if it is supplied with anything. And this is particularly important for the biomedical equipment section. Finally, we've entered in price estimates as a way to give a high-level estimate of the total cost of a given quantification scenario. These are estimates only, and prices are rapidly evolving, as you can imagine, based on market fluctuations. And so users are able to change the price if they have a different price estimate that they are using in country. And so to orient you to how this tab works is for a given row, which is a unique instance of a commodity, there are a number of care settings in which it can be used, and those would be inpatient care, isolation, screening, triage, and laboratory care. And so if you scroll to the right, you can see this first section is for inpatient care. So this is severe and critical cases, and the quantity per patient or per personnel, as well as the quantity per bed. And so you can see that we have personnel here on the left, so healthcare workers, cleaners, informal caregivers, ambulance personnel, and biomedical engineers. And the current estimated use of these given commodities. So for example, healthcare workers in the inpatient setting would need 1 protective gown per healthcare worker per day. We also give the ability to input based on patients. And so in particular for this section, this really only refers to medical or surgical masks for patients. And so here we've said that both patients, so both severe and critical patients, need 2 masks per day. And then the tool quantifies the total commodity need for this setting of care. So for inpatients, this is the total estimated commodity need for these commodities. So the same general structure then follows for other things. We have isolation, and this again are those mild and moderate cases. So here, that's really just informal caregivers, such as a spouse or a partner or family member, and the patient themselves. We also have screening and triage, and so this would be the healthcare worker doing the screening as well as the patient, and then recognizing that within the laboratories, so either laboratory technicians or cleaners will also need some sort of PPE or other hygiene equipment to carry out their duties. And so then finally in this column BE, the total quantity across all settings of care is calculated, and then the estimated cost based on the cost input that I mentioned earlier. And so this for all of these subsections, and we've included links to more easily navigate through this tab, as you recognize it can be rather large. So let me just scroll down to the biomedical equipment section, which starts here. It's this case management biomedical equipment. And here you can see the supplied with column is often filled out. So for example, a patient monitor with ECG, you can see that it's reusable and it's supplied with typically a number of other commodities that are not separately quantified for within the tool. And then again, you can see that we've applied various ratios for the need for these biomedical equipment commodities, either by patient or by bed or by both. And again, anything in blue is editable by the user. These are just the pre-populated defaults that were settled upon with the WHO OSL team that Elizabeth mentioned previously. So you can either accept these standard references, or you're able to input your own if you would like to change the use rates for any given commodity. So with that really covers all of the inputs that change how the tool calculates. So then let me take you to the user dashboard, where the user is able to adjust some of the potential scenario options and where the final quantification outputs are housed. And so there are three sections to the user dashboard. One is the where the user defines the infection and growth rate in the case estimation method. And in a moment, I'll pass it over to Justin to walk us through this in a bit more detail. But let me just walk you through the rest of this dashboard section. So here the user can enter in the way they would like to estimate cases, and then a number of other parameters such as clinical attack rate, doubling rate, etc. The user then can input the length that they would like to forecast commodities for. So the tool, based on the case estimation method that you've chosen, automatically will tell you the max number of weeks that you can forecast equipment for. So here it says the max is 22. So the user can say, we want to look at a 4-week, maybe a 4-week period of time. Or if you want to look at the total length of time that the tool forecasts for, you can say 22 in this scenario. The tool also allows users to allow for a potential lead time in terms of receiving shipments in country of 0 or 1 weeks. And then finally, users are able to develop a customized testing strategy. And so here there are really two high-level options of testing strategies. And again, as Elizabeth mentioned, this may be updated in a future version of the tool as we continue to refine the global approach to COVID-19 control. So we've highlighted in comments here, as well as the FAQ document, that there are really two testing strategies the user can select from. One is that users, or the tool will quantify for testing all suspected cases. And so this would be all cases that present, regardless of severity, and a set number of negative cases per positive case. And so to walk you through what this would look like if you had this selected, you'd say any suspects, and then for every positive test, the tool will assume that there are 10 negative tests. And this is the reference default. So this can be updated based on the current positivity rate in country. But this is what I believe is currently recommended by the WHO. The user can then enter in a customized testing algorithm. And so here we have across different case severities, so mild and moderate in isolation or severe and critical in hospital. You can enter the number of tests that you would like for given testing time points. So for diagnosis, here the current default is 1 test for diagnosis for mild and moderate patients and 1 for severe and critical patients. You also could have for release. Mild and moderate patients are not hospitalized, so they don't need a test for release, but severe and critical patients may have testing done to confirm that they truly are negative for the virus before they're released from hospital. However, if there are limitations or constraints around testing commodities, the user could override this and say, maybe we'll have no testing for confirmation of negative before release. So the user is also able to choose a targeted testing strategy. And how this works is, this is restricted testing of mild and moderate presenting cases if there are limited tests available. So under the targeted testing strategy, all severe and critical patients will be tested at the algorithm that's chosen by the user. And then for mild or moderate cases that are presenting for diagnosis, a set percent will be tested. And so here we have the percent set to 10%. So we're saying of the patients who appear sick but maybe don't have underlying health conditions, we will test only 10% of them to really focus on those high-risk patients. So let me now pass it over to Justin to talk a bit about the case estimation method that users can select, which includes either exponential growth and a basic SIR model or manual entry. So Justin, over to you, and I'm happy to navigate for you.
Thanks, Zach. So as Zach mentioned, this section here where we define the infections and growth rate is essentially the input which will be the first driver behind the quantification of commodities, because everything downstream is first based on the expected number of cases that would arise in the country or the territory that's being modeled. And so in this drop-down menu here, as Zach mentioned, there are 3 different options. And if we click on that drop-down menu, we do see the manual entry, the SIR model, and the exponential growth. Now, the manual entry option, which if we select, we'll see that we have a hyperlink which appears just to the right, which prompts us to click to then navigate to the manual case entry, which brings us to the patient calcs tab, as you can see in front of you now. And presented now are 2 main columns. In column B, we have the week label, which is just a serial number identifying the week. And in column C, the cumulative cases at end of week. So this method would be appropriate if the user has available to them another model that is, for example, a dedicated epidemiological model, which is producing an output of projected cases over time. And in this column C, the user would enter that cumulative caseload over time for each week. And in these blue cells, the user could easily override the numbers based on the output from that epidemiological model. We would suggest that this would be one of the best ways to interact first with the model, because epidemiological calculators or models will have a level of accuracy potentially that could go far into greater detail compared to the built-in methodology in this calculator or this ESFT. However, there are 2 built-in alternatives within the ESFT if the user does not have a dedicated epi model available to them. And so back in the drop-down menu, as you can see, we also have the exponential growth or SIR. So let's start with exponential growth. Exponential growth is just a simple way to calculate the number of cases that could be accruing over time based on exponential growth, on logarithmic exponential growth. And there's 2 main inputs to calculate this. There's the clinical attack rate and the doubling rate, which we'll review together quickly now. The clinical attack rate is within the population being modeled. This is now the proportion within the population that will be symptomatically infected with COVID-19. And so when you click on the drop-down menu, you're prompted with a series of categorical choices going from very low to high, and each has a proportion assigned to it, which you can see identified in the small note appearing immediately adjacent to the cell in cell D13. So low clinical attack rate is a 10% of the population, hence 10% would be clinically infected. This is essentially your ceiling for the total number of possible clinical infections among that population. Next is the doubling rate in days. And the doubling rate is essentially the speed at which exponential growth would happen. And precisely, the doubling rate is the number of days it takes in order for the number of cases to double in size. And similar to clinical attack rate, if we click on the drop-down menu, we'll see that there are a number of categorical choices again, from very low to very high, and each one has a specification identified in the small note in column D, which tells the user the value of the doubling rate. So for fast, as we've selected here, we're saying that the infections will double every 3.2 days. There is also options for manual entry for both clinical attack rate and for the doubling rate. So the user could choose to enter any information here that they have that would be more appropriate for the location being modeled. And we could enter those in here, and it would override any other such suggestion in the categorical drop-down menus. Finally, for doubling rate, there is an option called combined. And this is simply providing the user with the ability to change the doubling rate at one time point in the forecasted period. So here we could identify an initial doubling rate, which is entered by the user. Here, for example, 3. We then specify the week at which the doubling rate will change, and you enter the number here. So for example, here at the 6th week of our forecast, the initial doubling rate of 3 will switch now to finally the second doubling rate, which Zach can enter at 7. And this is in essence modeling some ability to suggest that the speed at which the epidemic is growing will slow. And this is customizable, as you can see. Now, exponential growth is a very crude way of approaching case estimation because it does not take into consideration all of the complexities of true disease transmission of COVID-19. And so a user may want to select the third option from the drop-down menu, which is called SIR model. So the quick disclaimer to provide to this group is that the ESFT is not supposed to be used as an epidemiological model. There are other dedicated epidemiological models and tools that have been designed which function to vary in a more precise manner, taking into consideration other types of complexities of disease transmission of COVID that should be used if available. However, the ESFT does provide the user with a built-in simplified version of an epidemiological compartmental transmission model. So very briefly, what is this? A compartmental transmission model is a model where we define different groups or subpopulations within a population, and the population will be divided amongst those groups, and based on certain parameters, an individual will progress linearly from one bucket or group to the next based on those assumptions. And this transmission model, this SIR transmission model, has 3 different compartments, the S, the I, and the R. The S stands for susceptible, so those people in the population who are considered to be susceptible to COVID-19. I is infected, those who are infected, and R, those who have recovered. And so a patient or a person within a population would go from one of these groups to the next in linear fashion based on a set of parameters or assumptions that determines how quickly they would move from one group to the next. And so what we have in front of us now, once we select the SIR from the drop-down menu, we're guided now to a set of menus in the SIR model step 1. And these are the basic transmission parameters that can be modified or accepted as presented by default from the tool that will determine how quickly someone goes from being susceptible to infected to recovered. Let's go through these quickly. First, we have the infectious period in days, and the reference value has been set at 7. And similarly to what you saw Zach describe in the Inputs tab, this section has a set of default values that the user could choose to accept. And you could click on the radio button. And when you do that, this is now the set of default parameters that will be used to drive the SIR model. However, if the user has better, more accurate information for the geography or territory that's being modeled, they could deselect the radio button and interact with any of the cells in column R to modify these transmission parameters. So as mentioned, the infectious period in days is the first parameter. The second is the current cumulative cases no longer infectious. So this is now, when you begin your model, the number of people who have been put or assigned to the recovered bucket. And we have an automated number that's being provided by default and calculated, or you could override that with more appropriate epidemiology if you have that available. The last two inputs here are the current average contacts per person per day and the probability of infection per contact between a susceptible and an infected person. These have been determined by default based on reference data and published literature that has modeled the current average contacts per person per day per country based on non-COVID transmission times. And associated with this, because of the linkage between contacts per person per day and the infection of probability of infection, we can also model the probability of infection per contact. And that is also proposed by default, but could be overridden if the user wishes to do so. Now, these are all calculated based on something called the reproductive rate, or R0. And the R0 is essentially a number which takes into consideration the contacts per person per day and the probability of infection between a susceptible and an infected person. And it's essentially a number which lets the user know how many secondary infections on average are generated from one primary infection. And so what we can have now under SIR model step 2 is the ability to manipulate either the contacts per person per day or the reproduction number to add in our modeling under SIR whether there could potentially be multiple stages in the future where we predict possibly different transmission parameters or different transmission dynamics to ensue based on potentially whether some interventions may change the way that disease transmission is happening. So by default, there's only one stage to the SIR model, but the user could override this and enter up to 5 stages. But for this demo, we'll just use 2 stages. Underneath, you can see we have a radio button, which provides the user the option to either toggle between reproduction number or contacts per person per day. And let's keep it on reproduction number for this demo. And what you can see scrolling over to the right is that under the SIR model step 3, we now have a table that appears. And we have the 2 stages, each represented by a row in this table. Stage 1 by default cannot be changed, but we can manipulate some of the parameters in stage 2. As you can see, stage 2 begins currently at day 0 of the forecasted period, but we can change this to any day that we predict possibly a change in the transmission dynamics of COVID-19. So let's presume that something happened 14 days or 2 weeks after the beginning of this forecasted period. And so we can enter 14 as Zach has done here. And what you can see is that in the first stage, in column AN, we have the reproduction by default set at 2.35. This is a basic reproduction number based on an unmitigated transmission of COVID-19. But let's presume that within the geography being modeled, something will happen and some interventions will mean that the reproduction number, or again, the number of secondary infections generated on average by one infected person, this will go down in some sort of manner and go from 2.35 to 1.8. You could enter any other reproduction number here based on your predictions and your estimations based on the epidemiology of the context or geography. And you could see how this affects the projected number of cases in the graph that's being displayed again to the right. And so in this way, a user could change the different parameters of transmission and as closely as possible based on conversations with government or other local stakeholders, they could then gauge what may happen over time to better try to estimate the number of cases being projected and hence being quantified for in terms of essential supplies, which is of course the main purpose of this tool. So once all of this has been set, the user can come back to the left of this tab. And I'll turn it back over to Zach to proceed to show you some of the outputs and the generated graphs and results from the tool. Thanks, Zach.
Thanks, Justin. So quickly in our last few minutes, because I want to make sure we leave some time for questions, I just want to orient you to how the tool displays the outputs. So we've added a number of graphs to help users interpret outputs from the tool, ranging from the total number of cases over the forecast period, broken down by severity type, and then the number of new cases each week so that you can visualize what the epidemic may look like over time. We then look at hospital admissions, so total admissions over the forecast period by severe cases and critical cases, and then the number of inpatient beds that are filled each week. And here you'll notice that the graph can sort of flatten out. And this is because the total number of inpatient cases is constrained by the available beds in a given geography. And so you can see that for critical beds, which are red, the total on the secondary axis, there's about 900 or so critical beds in country. And in this given scenario being modeled, that number is reached in week 2. And here we've pulled out so you can just easily see that the critical beds are maxed out in week 2 and really don't drop below that limit until around week 13 or so. Similarly, for severe beds though, severe beds actually never reach the cap. As you can see, we never really hit a plateau. And then here this says that the cap is not reached. We also have graphs showing total, focusing on diagnostics and testing. So the first graph is the total testing volume over the forecasted period capped by testing capacity. So you may remember that on the input tab, you're able to input the absorption capacity for COVID tests, and that serves as the ceiling for number of tests. And then in this case, that number is the same given the parameters we put in. But we have a second graph that shows if you were not to constrain testing capacity based on available resources, what the total testing volume would be over the forecasted period. And that's broken up by testing time point. And this again is impacted by the testing algorithm that the user inputs on the dashboard tab. So if you remember, we said that there was no tests for the release of severe and critical patients, and therefore we have no tests allocated here. We also have a graph showing the estimated cost breakdown by item category. You can see that the total estimated cost for this quantification is about $63 million US. And we have a graph for the number of healthcare workers needed each week. And this can be constrained either by bed capacity or healthcare worker capacity. And you can see that this sort of mirrors the inpatient beds graph, where inpatient healthcare workers do reach a cap at about 2 weeks, as we essentially cap out. We also have some of these high-level results in tabular form that go along with these charts. And then a number of other tables that show the needs over time. So we have the number of healthcare workers and staff required over time by setting. So inpatient healthcare workers each week of the forecast, healthcare workers for screening or triage each week of the forecast. We also have patient numbers and bed availability over time. So the number of severe cases needing beds, the number of cases that are in a bed, the percent bed occupancy or the occupancy rate, both by severe and critical patients, and then for patients in isolation. And those would be the mild or moderate patients. So really just trying to provide users with a number of ways to interpret this data. Finally, this last section is the detailed equipment quantification. And you'll notice that this table mirrors that on the equipment list and usage tab. Here we pull out the total quantity needed and the estimated price. Again, that is input by the user. And all of this is summed up at the bottom for this estimated total price broken by category that mirrors the waterfall chart earlier. But this will be the primary output of the tool. And again, this is based on the number of weeks that the user is forecasting equipment for. So that brings us to the end of our tool walkthrough. I know there have been some questions along the way that I think have been actively answered. So thanks everybody for adding those questions. And I think we can open the floor for any questions now or continuing through the chat box.
Hey, great. Thank you, Zach and Justin and Elizabeth, for taking us through this tool. As you mentioned, Zach, there have been a number of questions that have come from participants that I believe everyone should be able to take a look at if you may feature Zoom. A couple outstanding questions. One comes from Jim Rosen, who's asking the quantities and costs are for what time period?
Sure, so they're for the time period that's designated by the user. So you can either, in this cell here, so however many weeks that you want to forecast for is what you'll put in here, and the tool will calculate the quantities and costs for that period.
Well, thanks. And then Jacob has also added some thoughts as well about how this tool is very comprehensive in that it combines some of the morbidity drivers with some of the product logistics aspects. And I guess a question that I might ask in line with Jacob's comment, have you guys had feedback from users for this tool in terms of either what teams should be brought together to complete this tool, or what resources you might recommend turning to complete assumptions around things like clinical attack rate or doubling rate, things that some of our logistics users might be less familiar with?
Thanks, Joe. I can take this question. And it's a great question because the comment makes a great point that there are a number of clinical aspects that need to be taken into consideration in order for this tool to really function properly and to generate appropriate forecasts. And so we do recommend that close communication and collaboration be had with local experts within ministries of health, clinical departments, and epidemiology departments, because of how closely linked, of course, the quantification is with the estimate of patient caseload over time. And because those two things are so overlapping, there is an important need first to carefully consider some of those initial components before the logistics side can sort of unfold and be calculated via this tool. So we do recommend those collaborations. However, the tool, of course, is also presenting a certain number of default parameters. And so as you've heard Zach explain, especially on the inputs tab, much of the clinical background, when we think about, for example, the disease distribution by patient severity, many of these clinical aspects have at this point been documented well enough. And while there may be certain differences across various geographies, some of these, such as the patient case severity breakdown we discussed, can be used by default. And so the user can choose to accept the default values that are being provided. The one area, of course, where we would stress a little bit more communication and a little bit more thinking is on the case cumulative estimation cell, which actually is in front of us right now on screen in cell C12. And the selection of various parameters here could greatly change or vary the number of patients estimated over time. So careful thought needs to be put there. Thanks for the question.
Yeah, thank you for that response, Justin. Another question we had is from John Durkovich. Is there any advice if we're looking ahead to a 2021 wave, whether there's specific areas we could go in the tool to adjust, things like population?
Hi, I'll take this question again. Thanks, Joe. And it's a great question. Just to reiterate, to make sure I understood, the question is about the long-term future of COVID transmission and potentially beyond 2020 and looking into 2021. And so the answer here is that we are facing, quite a long road ahead in terms of where we are today and how much work there is to completely suppress transmission at a global level and also across many countries. The tool that we have here at ESFT, as you saw, can project and forecast up to 52 weeks ahead of today. However, the recommendation is to use the tool for shorter periods of time. And that's because of how unpredictable the nature of disease transmission is and how variable and fluid the situation has been from country to country, which depends greatly on a government's response and the way that it's been tackled from place to place. And you've seen, I'm sure, reading the news, how different it's been from location to location and how quickly also things can change. And so very long-term predictions are very tricky. And there's a lot of disease modeling happening today. However, for the supply quantification and the specific use of this tool, the recommendation actually is to use this for shorter time periods of up to 3 months. And the reason that is because within that time frame, there is a better amount of certainty, or less error, to put it in other words, around possibly the numbers being generated. But because of how fluid the nature is, any very long-term kind of projections become very difficult to use in a meaningful way. So in short, we would recommend using this tool for shorter time periods. However, there could be need for longer periods of time into the future to keep thinking about how we can continue forecasting supply needs for fighting COVID-19.
Great. Okay, thank you for that, Justin. I think we're just about coming to the end of our time together. With that, I think we'll close out our session, and I just want to make one more plug to see you all next week, June 16th, 12 to 1 p.m. Greenwich Mean Time. We'll have a walkthrough. I can share my screen. We'll have a walkthrough of a supply planning tool to complement this forecasting tool for COVID-19 commodities. And also, of course, I'd like to join IAPHL if you're not a member, or if friends who are not members at IAPHL.org. And I think that takes us to the end of our session. Rachel, will be a recorded version of this session available?
Yes, we will be sending out a recording of this webinar, so you can refer back to anything that we've talked about now, and we can also sort of gather all the questions that were asked and make sure those are all answered and sent out to everybody.
Excellent. Thank you to our panelists, Elizabeth, Justin, and Zach, and thank you to all our participants for joining us today. And if there's additional conversation, feel free to take it over to IAPHL.org. Thanks, and see you again next week.
Thank you.